Good morning, Dr. Rajudri.
Morning,
Okay.
morning, Dr.
Yeah,
Shah.
yeah, yeah, yeah.
2 minutes late. So I will just quickly share the screen.
Yeah. Good morning. Today we'll have a MRI session on hepatobiliary disorder. Dr. Shubhra Raichudhuri, who is a renowned interventional radiologist at Fortis Hospital, Kolkata, will take us through these MRI pictures, and I hope he'll be able to answer in the exam. Dr. Raichudhuri will brief you about the basic things about hepatobiliary MRI. Dr. Raichudhuri, please.
Thank you. So there are two separate talks. So I've just dug out. One is a very old talk from my childhood. Uh, this is a talk that I think it is from 2004, but it is still very relevant. And this is what I will maybe start with. Okay, so this is titled "Imaging the Benign Biliary Tree." Mainly concentrating on MRI, but there is also a little bit about what we can do with CT scan. So, but this is mainly on MR. I'll do this first, and then there is a more modern and a more sort of up-to-date talk, of which I will show you some slides because there is some things about the postoperative biliary tree that is relevant to the surgeons. So, so just starting this one. So in this talk, I'm going to talk a little bit about detection of biliary stones, talk a little bit about abnormal biliary anatomy, postoperative leaks, post-cholecystectomy syndromes, biliary dyskinesia, and some other benign biliary conditions. So this is not about malignancy. This is not about the other big area where we use MRCP, which is gallbladder cancer or a biliary cholangiocarcinoma or even a pancreatic carcinoma. Prior to planning for an ERCP or a PTBD or a PTC, we would consider doing an MRCP to look at the biliary anatomy, to look at the level of the obstruction. So this talk will not cover the malignant part of biliary obstruction. So if you look at the imaging modalities that are available in terms of looking at the biliary tree, you start with an ultrasound, then you consider an MRCP. In those days, we used to do this test called CT cholangiography, which is a very, very, very good test. Unfortunately, the contrast agent that we used to use is something called biliscopin, which is a contrast agent that used to be excreted into the biliary tree. So it was like an active excretion by the liver into the biliary tree to identify and delineate the biliary tree. That contrast agent became, so for some reason, it went out of fashion and is not produced anymore. So CT cholangiography is not done anymore, but it used to be a superb test. Then, of course, we have EUS. See, I'm talking about EUS even in 2003, 2004. It is, of course, far more prevalent now than in those days. And then we have the more invasive modalities, which are ERCP, PTC, or intraductal ultrasound. And what you guys would consider doing is an intraoperative cholangiography. So that is the set of imaging modalities that you would use with increasing invasiveness from ultrasound to intraoperative cholangiography. So if you start with transabdominal ultrasound, it is the most cheap, most widely used, most basic test. It's actually a very, very good test for gallbladder stones. And this is something I would like you to mention, that, that when you are in the exam and somebody shows you a CT scan of a gallbladder or of the liver, you have to understand that only about 40% or 50% of gallstones are visible on CT. Because of the cholesterol content, they're not dense enough to be seen on CT. Now, there are some softer signs on CT where you can see it as a filling defect within the bile, but a calcific rim of a gallstone or of a gallstone content, you will only see in 50 to 60% of cases. So ultrasound remains the standard of care for detecting gallstones. Now, when it comes to MRI, even compared to MRI, ultrasound is a better test to detect a gallstone in a well-distended, fasted, 4 to 6 hour fasted gallbladder. The reason is simply this. That remember that MRI, by its very nature, like I talked to you previously, MRI is not a great spatial resolution scan. MRI is a great contrast resolution scan. In other words, if you are wanting to detect a tiny, tiny little structure, MRI, because the slice thickness are a little wider, may miss a tiny, tiny little stone, particularly the standard MRI. Now, the way to get around that I will talk about, but basically, if you ask me a single line answer, what is the most sensitive test to detect a gallstone? The most standard answer would be an good quality, high resolution ultrasound. Now, how can I get around this? Of course, if you do CT cholangiography, CT is very, very spatial resolution high. So therefore, you can detect tiny stone, but we don't do that test anymore. So when we do an MRI, we have to do what is called a volume sequence. And I'll show you examples of a volume sequence. So typically, and it is a pretty routine now, you as a surgeon, if you're given this as an exam, if somebody asks you that, when you talk about the MRCP, the typical picture is what is called the MIPT image, right? It is a summation image of the whole of the bile duct. It's called the MIPT image. So if your examiner asks you that where is the gallstone, I think you should say that, sir, this is a MIPT image. I might not be able to see a tiny gallstone on a MIPT image. I want to see the source thin section image. And that thin section image is a volume. So if you go through the volume, like in CT, you are not going to miss a gallstone, even if it is tiny. But ultrasound, of course, is patient and operator dependent. It requires a fast. Now, this is for gallstone. Ultrasound is not so great for CVD stones. It can give you an upper duct diameter. Oftentimes, the lower duct is not so well seen. So, sensitivity for CVD stone is only about 50%. Negative predictive value is 78%. Whole CVD is only seen in 60 to 80%, like I said. So a typical example of gallstone on ultrasound, you can see the stone, and it typically will cause an acoustic shadow, right? That is the reason why you would call a stone. Now, suppose, so ultrasound is a basic test to detect a gallstone. But if your LFT is abnormal, if your bile duct is dilated, if there is a history of jaundice or cholangitis, what is it? Charcot striae, right? The sign of a. So if you have the triad of cholangitis, fever, and jaundice, if you have a dilated CBD, and how do you call a dilated CBD? Basically, the decade of the patient plus 1. So if somebody is in the 4th decade, bile duct diameter should be 5 millimeter. Above that is abnormal. 6th decade is 7 millimeter, like so. Okay. Remember that post cholecystectomy, your bile duct will dilate. So this applies to a non-post cholecystectomy bile duct, decade plus 1. So when do you do more? So before ERCP, because there should not be anything called a diagnostic ERCP. I think that we are all agreed that we should not do a diagnostic ERCP. Biochemical indicators are raised bilirubin, raised alkaline phosphatase, and colicky pain, history of cholangitis, dilated duct on ultrasound, history of biliary pancreatitis. So these are the indications to do something more. So then what do you do more is this test called MRCP. It is the most established non-invasive test. It is 95% accurate, lower negative predictive value in small duct. It is a little bit artifact prone, so therefore sometimes movement will cause a problem, and I'll show you some artifact. But resolution can be down to 2 millimeters. And this is the problem. Maybe in today's age, this is an old slide. In today's age, you can say that the resolution is down to 1 millimeter, but you will still potentially miss a grit, what we call a bile duct grit, which can cause pancreatitis. And this is one place where I would say a dedicated targeted endoscopic ultrasound, whereby a good operator is operating, will be able to diagnose the grit, tiny, like sand, which MRCP.
Non-participants, please mute. Dr. Chirag, thank you.
So that it is technique dependent. But it is less on the operator dependent. It is not so much operator dependent. And there is another thing about MRCP. There is poor ampullary visualization. And I will tell you this: if you look at the picture of MRCP, oftentimes you will see the bile duct coming down, and right at the ampulla, the duodenal interface, you will see a filling defect. That filling defect is not a stone. You understand? A stone will typically have a meniscus or a filling defect, but loss of signal at the duodenal interface is normal. And that is something of a problem with MRCP. And of course, there can be artifacts, and artifacts can be because of respiratory motion. Artifacts can also be because of bile flow, because any movement causes problem in MRCP. So due to biliary flow, it can cause artificial filling defects. So this is a standard MRCP. If you look at the intrahepatic bile duct, this is the duodenum. This is a bit of the gallbladder, cystic duct coming like this. Can you see my arrow, Makunda?
Yes, yes, you can see.
So here is a cystic duct coming down. So this is the intrahepatic duct, common hepatic duct, cystic duct joining. This is the bile duct. And here is the ampulla. Just at the ampulla, this is the pancreatic duct, right?
Yeah.
So in this case, you could say, depending on the age of the patient, of course, you could say that there is a little bit of dilatation of the proximal CBD, and there is also some prominence of the pancreatic duct, right? So not quite a double duct dilatation, not quite, but I would look very carefully at the thin section at the ampulla to see whether there is any soft tissue mass, whether there is any possibility of stricture. We'll talk about a lot of other things that can cause this appearance. And remember one pitfall, which is the duodenum. The duodenum is water filled. Now, in the old days, we used to go crazy about reducing this. We would give agents that would make the duodenal signal disappear so that we can see the bile duct very well, right up to the ampulla. But nowadays, because we have got so many other things, do excuse me, so many other things, we don't do that. And there is another thing about technique I would like to talk to you, is something called secretin induced MR pancreaticography. So secretin is is a hormone that can be used to inject so that there is active excretion from the pancreatic duct. So if you wanted good pancreatic duct visualization, you could do secretin induced MRCP, and that would that will show you the pancreatic duct very well. So typically a gallstone will appear as a filling defect. A gallstone will appear like this, like tiny, multiple series of calculi. And you can see that Steinstrasse, it is called a line of stones, where you have got a street. Strasse means street. Stein means stone. So Steinstrasse means a street of stones like this. These are bile duct stones. And here is the cystic duct again. So whenever you look at an MRCP, look at the intrahepatic ducts, look at the common hepatic duct, identify the cystic duct entrance point. Is it low? Is it medial? Is it on the left side? I'll show you examples of all of that. And are there, and look at the ampulla, look at all those things. Now, coming to some of the pitfalls of MRI, and those are important. Say, for example, a slightly non-distended gallbladder. or for example, the colon will cause compression. You know, the hepatic flexure of the colon lies very close to the gallbladder. Sometimes on the 3D MIPT image, if you have this sort of appearance, it can be because of the colon indenting. If you have it well distended, then you see that it is gone. I cannot now remember what this was. Sorry, apologies. So this looks to me like a stricture, multiple strictures in the bile duct, right? So this is segment 6 duct that is dilated with a stricture. Here is segment 2 and 3 duct joining with a stricture, but I cannot remember what I'm trying to show here. This is an artifact. This is the one that I was talking to you. Movement related artifacts can cause all sorts of artifacts. And I don't want to talk about CT colonoscopy, not CT colonoscopy, CT cholangiography for a non-obstructed patient with a bilirubin of less than 50 in Western numbers. So that applies to about 2.7 bilirubin in our terms. But it used to have fantastic resolution down to 1 millimeter and to see within up to the third order ducts. And it gave you an idea of function. It told you about leaks and pancreatic biliary reflux, and it showed much better the ampulla, because the ampulla has got as I said, loss of visualization of the ampulla on MRCP. So these are my old pictures from CT colonoscopy, but you can see that bile duct visualization and lack of filling here consistent with stones. And you can see the stone as a filling defect, right? You can see all sorts of pictures. So I'm not going to talk much about this. These are all CT colonoscopy pictures. You can see intrahepatic stones as well. So back to MRCP, right? Okay, so then the next test is, of course, ERCP. It is the supposedly the gold standard. You know, I think in our all old surgical textbooks, it was talked about as the gold standard. It is certainly not the gold standard. Stones are missed, particularly in big ducts. It has got an unacceptable morbidity as a screening test in terms of pancreatitis, perforation, sepsis, and bleeding. There is a mortality, there is a morbidity, and there is a mortality with ERCP and pancreatitis. But it is a dynamic test. It can intervene at the same time. A certain postoperative anatomy it is unsuitable, but it is a great test to remove the stone. It is a great procedure to remove the stone. I don't think it is a great test to diagnose the stone. So this is what is important for you. You have to understand that a basic principle of radiology, and that applies to everything that we do, you know, all the days of the barium, and you know, in your batch I have not spoken about this, and this is a basic concept and principle you must have, is that what is called luminography versus cross-sectionography. So when you are doing a barium test, or when you're doing a fluoroscopy test, anything, whether it is a coronary angiography to a barium enema, to a small bowel contrast enterography, to an ERCP, whatever is a fluoroscopic test where you are looking at the X-ray screen and you've got a planar view, 2D view. You're looking at the bile duct like this, and you're looking at it in one plane. You can look at it in 2 planes, 3 planes, 4 planes, but you're looking through the width of the bile duct, right? If it is a colon, barium enema, you're looking through the width of the colon. If it is a coronary artery, you're looking through the width of the coronary artery. When you're doing a CT or MR, remember, you are cross-sectioning, slicing that artery, that bile duct, that colon. So you can see the lumen, but you can also see the wall. And you can also see what is outside the wall. So this is a basic principle of radiology, is that cross-sectionography is superior to luminography, because not only can you see the inside, but you can also see the wall on the outside. Did I get this bit clear? This is very important. This is why ERCP as a diagnostic test can never be superior to MRCP, or when it comes to EUS, it's a different matter because EUS is again cross-sectional imaging. You understand? Because you are actually looking at the wall of the bile duct as well as inside the bile duct. You're looking at it. I'll come to EUS in a second. So this is the ERCP. You can see the filling defects in a very dilated lower bile duct. EUS, on the other hand, is a very, very good test. It is operator dependent. Duct visualization is improved nowadays, but it is not 100%. It's about 70, 80, 90%. High resolution imaging from very, very close. It can detect tiny stones and sludge. It is more sensitive than ERCP, but when the duct is seen and a very low procedural morbidity, very low procedural morbidity, 0.5%. The disadvantage is intrahepatic ducts are not visualized. So here is a picture of the CBD. CBD with a stone. Can you see the stone? Intraductal ultrasound, very expensive, invasive, not widely available. It is now because we have got spyglass now. Very high resolution images from within the bile duct. It can be used as a problem-solving tool, but it can change management because you can see things that you cannot identify with other modalities. Lastly, I want to talk about intraoperative cholangiography, cannulation done at laparoscopic cholecystectomy. It probably is the closest to the true gold standard, probably, because you can also, troll and you can also identify, but there is a risk of CBD injury and longer operative time. So what is the gold standard? It's a difficult issue. It depends upon who is lecturing. So, a very good gastroenterologist will convince you that ERCP is the gold standard. It is not. EUS perhaps is the gold standard, but when the duct is seen. So if you ask me, and of course, like in any gold standard, we talk about follow-up, that for the one that was negative, was it truly negative? If you have a follow-up and the patient did not present with anything to do with biliary stones, then you can say that it is a gold standard. But in today's day, I would say that a combination of MRCP and EUS is the gold standard. So MRCP,
Rajendra, one comment. The latest in imaging, I think in investigation is we have now cholangioscopy. You have a ERCP scope, and through this a baby scope goes in, and the endoscopist can manipulate this cholangioscope into the bile duct lumen, and you can see the interior of the bile duct. That is now called as cholangioscopy.
So but that is spyglass, Makhanda. That's
spyglass. Yes, spyglass cholangioscopy.
That is what I mentioned.
It's not available in everywhere.
No, it is available in our hospital. It is. But I'll tell you, the problem is let me here, I put it here. Look, intraductal ultrasound. We can even do an intraductal, not only a spyglass, you can also do intraductal ultrasound with the endoscopist can go through the mother scope and then through the bile duct. The problem is, Makhanda, you see, you are right that it can go and see the bile duct, right?
Yeah.
Now, let me tell you this because I have investigated this very well. Suppose colonoscopy, right? Supposed to be the gold standard for colon visualization. Do you know how much of the mucosa is missed on colonoscopy? 23%. Because when you are going in like this, right? Yeah. If you have got a fold, you will not see the other side of the fold. You're not, when you're coming back, you're coming back like this. You're not coming back pointing like this. So there are lots of other issues,
Yes.
So intraductal imaging or intraductal, even a spyglass, that is number one. Number two is, do have a look at the completeness of the spyglass to investigate the whole of the bile duct. It is not so easy to look at the whole of the bile duct.
Yeah, very difficult.
They are not able to look at the intrahepatic bile duct. So only day before yesterday, I was talking about doing a spyglass. We have spyglass. talking about spyglass from the percutaneous end, because I had a very difficult biliary stricture which looked malignant, but we have tried biopsying it 3 times. I've done endobiliary biopsy, I've done endobiliary brush, we have done percutaneous biopsy, everything is negative. So we, the difficult situation you have sometimes with biliary strictures to try to prove whether benign or malignant. CA99 is 4,900, but we can't prove malignancy.
Yes,
So
yes.
we can go through the percutaneous route also to do spyglass. So we did spyglass and we did, biopsies. We'll wait to see. There is some evidence to suggest that spyglass improves the biopsy return rates. Of course, spyglass is very, very good for, detecting any biliary anatomy that is difficult as a problem-solving tool. There is absolutely no doubt. My problem with calling any one technique as a gold standard is that you do not, when I'm trained to do EUS, when we were taught that EUS is the gold standard. So I asked this simple question that, okay, what is the percentage of success of visualization of the whole bile duct? In what percentage? So various experts will tell you that at least 30, 40, 50%, I will go up to 80, 90%. So in 10, 15% of cases, you're not even seeing the whole bile duct. So then how is it the gold standard? So EUS is the gold standard when the whole bile duct is seen. I think that should be the term, that it is a gold standard when the whole bile duct is seen. So all of these tests have got their individual limitations, and we have to have a balanced opinion. Now,
and regarding intracoloniography, with the advent of MRCP and your EUS, almost no surgeon is doing intracoloniogram nowadays.
I know. Vahandar, this is a very old slide, but you understand that's why I said to you that it is not true today. Absolutely, you're right. Now, just a few words about abnormal anatomy. It is important very important for the surgeon to know what the abnormal anatomy is. So it can be a major anatomy abnormality, a minor. In 24% of cases, it is a major cause of ductal injury. So the typical ones are aberrant right hepatic duct. Right hepatic duct aberrant means it is inserting lower than usual. Oftentimes, it can be the right posterior duct, that is a separate insertion lower down. Only last week we had a case. You can have a long cystic duct, and that can act as a stump, and it can be one of the causes of post-cholecystectomy syndrome. You can have a low or medial cystic duct insertion, and that is not uncommon at all. And this is very important because I think nowadays you guys have got robots and stuff. You have got fantastic visualization. But in the old days of colored triangle, me as a surgeon, when I was taught, I remember this very clearly, that the medial most structure was supposed to be the bile duct. But if you have got if you have got a low medial insertion, you have got two parallel structures in the lower CBD, and you can mistake the CBD to be the cystic duct, and you can clip the CBD and cause a bile duct injury or a stricture. So these are important structural anomalies that you need to be aware of. And then lastly is abnormal pancreatico-biliary ductal union. The common channel between the pancreatic duct and the bile duct, if that does not, it's one of the causes of reflux. And if you have got reflux, then it is one of the supposed causes of pancreatitis, right? Idiopathic pancreatitis. So abnormal anatomy. So here you are, you've got a low medial this is a low insertion. No, so this is a right posterior duct inserting low. Okay. Here is a low insertion, or this is also a very low insertion of one of the intrahepatic bile ducts. This is a low medial insertion of the cystic duct. And this is, we wrote a case report of this. So this is the accessory segment 6 duct of Luschka. Taito, cholecystohepatic duct.
Yeah.
This is a CT cholangiography, and this is so this can be a rare cause of bile leak, and a cause of bile leak which is not identifiable easily is a duct of Luschka injury. So now I come to post-operative biliary tree and biliary strictures. I'll briefly talk about the quickly now. So you can see this is a loop of jejunum, right? And this is a choledoco,
Maybe,
choledoco hepatico jejunostomy. So this
yeah,
is a hepatico jejunostomy, and this is more likely to be a choledoco jejunostomy, where a bile duct, irregular stricture, joined to this is a bile duct, whereas this is the bile duct confluence which has been joined with a roux loop of a jejunum. So this is a hepatico jejunostomy. So they're prone to get strictures. We do a lot of this dilatation of these strictures, and of course bile duct leaks. And bile duct leaks, MRCP is a good test. ERCP is a great test for bile duct leak because it is an active injection. And you can see, so this is a cystic duct stump leak. This is also a similar sort of cystic duct stump leak. You can see the fluid around. And of course, you can see with PTC, with exquisite detail, you can see when you identify, biliary, if you can inject down the bile duct. So just a few other quick conditions. Mirizzi syndrome is something important for you guys to consider. Mirizzi syndrome is a stone or inflammation in the gallbladder neck, most often due to the stone. And because the stone is in the gallbladder neck, it causes the inflammation. It causes the stricture or causes a narrowing of the common hepatic duct. And it can look like a cancer for all practical purposes. It looks like an abrupt stricture, but it is a smooth stricture, smooth compression. It is not irregular. There is no shouldering in Mirizzi, and there is upstream dilatation of the bile duct, and there is patient presents with obstructive jaundice. So these are examples of Mirizzi syndrome. You can see the gallbladder neck stone, and you can see a little bit of intrahepatic bile duct dilatation. Once again, a smooth stricture, deviation of the common hepatic duct due to the gallbladder neck dilatation. One few terms about the post-cholecystectomy syndrome. It is a not and very uncommon clinical condition that a patient presents with right upper quadrant pain or dyspepsia or early satiety. The typical biliary symptom complex. They get a surgery and their symptoms do not disappear. The most important cause, and I will be educated here, but I'm talking to surgeons, they know this very well, but the most important cause of this is actually that there was something else in the first place. It was not the gallstones that caused it, that it is that the symptoms were being caused by peptic ulcer disease,
GRD, GRD.
Gastroesophageal reflux disease, or even something like right-sided irritable bowel syndrome, some sort of a non-biliary problem, and the gallstone was incidental, which is true in most of the cases. Now, I would love to hear your opinion on this. So in the West, we were always told that a gallstone only rarely needs an operation. In our country, of course, a lot more gallstones get operated. There may be more than just scientific reason for that. But it is also true that our country is in an asbestos belt. Long-term gallstone in our country often leads to malignancy. And therefore, there is a far more higher reason to operate for gallstones in our country. So what that means is that you're oftentimes, not often, sometimes you're removing the gallbladder, but you have not addressed the original problem. So that is the most common cause of post-cholecystectomy syndrome. But there are some anatomical causes, and those are these. Retained stone, for example, you can see a cystic duct, particularly if you've got a long cystic duct remnant. And then comes this concept called biliary dyskinesia, type 1, type 2, type 3, correct? 3 types of biliary dyskinesia. So the important condition of biliary dyskinesia that we need to understand is sphincter of Oddi dysfunction. It's a poorly understood condition. I haven't read on this for a long time. I don't know if there is any recent evidence on this, but sphincter of Oddi dysfunction basically means that, like any sphincter in the body, whether it's the esophageal sphincter or the sphincter of Oddi, see, when your biliary peristalsis is coming down, the ampulla has to relax at the same time. If this coordination is lost, that the ampulla doesn't relax when the bile is coming down, you're going to get pain, you're going to get dilatation of the bile duct. Okay. Now, this can be because of type 1, 2, 3, right? So there are defined diagnostic criteria. It can be psychosomatic, but our job is to exclude a structural cause. So the gold standard test is a biliary manometry. If more than 40 millimeters, it is diagnostic. Now, things like an active excretion of the bile duct, for example, a HIDA scan, can have a diagnostic impact. CT cholangiography, nowadays we have got pre-movist MRI. I'll show you the pictures in a second. And I may be wrong here, Makunda.
Yes, there is a role. If you can demonstrate that is a sphincterotic dysfunction, excluding other causes, there is a role for doing a sphincterotomy.
No, but after 3 types, where do we do a sphincterotomy? Type 1. Because not in all of them do we do sphincterotomy. So, okay. Next time I'll read up and I'll talk about this. I'm sorry, I've forgotten. I used to know this. Okay, acute cholecystitis. Let me not talk about this. Okay, very briefly. So acute cholecystitis, gallbladder wall thickening, pericholecystic fluid, presence of stone. On CT, again, wall thickening. On X-ray, you can see the salute sign of the distended gallbladder. It's just a exam question, but basically you don't diagnose acute cholecystitis on X-ray. Can you see that? And when you have the same features but without the presence of stone, then it is an acute acalculous cholecystitis. Choledogal cyst.
Dr. Raichudhuri, how do you differentiate between a inflammatory thickening versus a neoplastic thickening?
Okay, good, fantastic. So inflammatory thickening will typically have, like this picture here. Look at this picture here, or look at this picture here. So inflammatory thickening is smooth, edematous, non-nodular, with a very clearly defined plane with the liver. Whereas a malignant thickening will be more enhancing, nodular, with irregular plane with the liver, and if you have a smooth layer of pericholecystic fluid, then that is more likely to be benign than malignant.
Yeah.
So those are the 4 things. Let me see if I've got. So very quickly, choledocal cyst, very important.
Before that, Dr. Bhomik has asked a relevant question. Often, patient having a biliary leak, after ultrasound, surgeon jumps doing a MRCP. But most of the time, we find that if there is a significant collection in the gallbladder fossa, a MRCP is not helpful. What's your opinion? When you do MRCP, if you suspect biliary duct injury in the immediate post-op period?
It's a very good question, actually. And the problem, if you have a large pericholecystic, liver gallbladder bed or a subclinic collection, it will obscure the bile duct.
It will all white with the bile.
Yeah. So I think ideally you should put a drain and then you should do the MRCP. But in certain cases, Makunda, because we are a tertiary center, a lot of the cases come from outside. So they would have had a lot of things done. So we would, just to see what is the overall picture, we would actually do an MR study.
No, agreed. But what I'm saying is not, suppose it is leaking today, getting
Yes.
a MRCP in 3-4
Yes,
days
yes.
time with the bile draining out may not help.
Absolutely, absolutely true. Absolutely true. So again, I miss this study so much. The CT cholangiography study. It used to be so elegant, so
Yeah, yeah.
beautiful. study
It can
to
show the leak
demonstrate.
very clearly.
Yes. So
Now people
cholangiography-
are saying that 3D ultrasound can show the dynamic leak. They are saying that you can, in fact, demonstrate
got
that
this
bile is
3D.
leaking out in the bile duct.
Yes, I was never a fan of this 3D ultrasound.
Yeah.
We have it also in the endoanal space, right, Makonda? That
Yes.
we have in pelvic floor imaging, we have this. Somehow I cannot with the baby and the fetus, it is even 4D ultrasound. So I don't know, boss. I am just a very old-fashioned person. Cross-sectionally, if I can see something like a bread, slice it like a slice of bread, and you can see. So these 4 types of colorectal cysts you guys
Yeah.
know, right?
Yeah.
So the pictures are self-explanatory. Type 1. Type 2 is the saccular one, which is you need to know this. And of course, as you go further up into the intrahepatic bile duct, it becomes type 3, 4, and 5. Can I ask you something, Dr. Shah?
Yes.
What is your strategy with a incidentally found colorectal cyst?
Most of the time we say, particularly if it's type 1 or we venture to operate because it's considered as a pre-malignant lesion in
Correct.
biliary. So, but you see, if say type 5 means you cannot operate by a general
Not a
surgeon,
type
you
5.
have a transplant.
Type 2 is relatively okay and easy for you guys to operate.
Yes, type 1 and type 2.
Type 1 and type 2. Huh.
Yeah.
Okay. Okay. So you would electively operate, right?
Yes, yes, we do.
Okay. Some other just side-by conditions. Adenomyosis of the gallbladder, not uncommon at all, often incidental, can be associated with gallstones. So basically, adenomyosis, as you know, the condition, it is presence of secretory glands within the wall of a structure like the gallbladder or the uterus. So intramural in the uterus, you can see same in the gallbladder. So they appear as little tiny T2 hyperintense or like this little projections from the lumen of the gallbladder. Questionable significance unless they are associated with gallstones. You need to be able to distinguish between a gallbladder polyp and adenomyosis. A gallbladder polyp, on the other hand, is important. If you see a gallbladder polyp, particularly more than 5 millimeters, in the very least, they must be followed up. In our country, it is very important because our country is a high risk of gallbladder cancer, and we don't want to miss an early gallbladder cancer. So therefore, gallbladder polyp is something that we need to take on. So regarding this part, and I will just take 5 more minutes of your time. So the take-home messages from this part is diagnostic ERCP should have a little role. ERCP is not the gold standard. We must image before intervening. MRCP is very widely used. Forget about CTC. EUS in good hands is a very good technique and probably the true gold standard. So thank you very much. I am just going to quickly okay. Sorry. Don't want to show this one also.
How can you pick up Mons?
So that is Mons was stones, groans, and so that is typically for parathyroidism, hyperparathyroidism, right? That is the that used to be that, if I am not wrong, this is belly and love, if I'm not wrong.
Yes, very love.
It is, that was to do with hypercalcemia and
Yes.
because they get psychiatric illnesses, no?
Yeah.
I
Yes,
think that
yes.
is belly and love. Okay. So there are so some more pictures. So I just wanted to show you this. So so on MRI, so you wanted to briefly go through the anatomy. I'll do that. Let's see the picture. So typically gallstone, acoustic shadowing, gallbladder wall not thickened, no pericholecystic fluid. This is coronal MRI, not a great picture, but this is to show the stone in the gallbladder. You can see the filling defects in the gallbladder that is packed with stones. So this is the liver, guys. Okay, this is the intrahepatic IVC. This is part of the aorta. Okay, these are loops of bowel, spine, psoas, and this is the intra-abdominal fat. Are you okay with this bit? Whatever
Yes.
little I can see. Okay.
Yes.
This is what I meant by a gallbladder polyp. This is the polyp of the gallbladder. This is the stone.
The differentiating between a polyp and the stone is by acoustic shadow or some more points?
Okay. So the first point is acoustic shadow. The second point is it is hanging dependence. So if it's a stone, then if you change the patient position, the stone should drop, right? It should change the wall, whereas a polyp will not change the wall. This is something like adenomyosis, like we talked about. So this is a classic acute cholecystitis. I think you were asking me, Makonda. So here is the thickening of the gallbladder wall, edematous thickening. You can see a line of fluid that is a pericholecystic fluid. You see the fluid between the liver bed and the gallbladder wall. And here is a stone in the neck of the gallbladder with acoustic shadowing. Now, similar patient on CT, you can see the thickening of the gallbladder wall, but you cannot see the stone because I said to you that the stones are not always seen. And this is interesting. This is, I think, I will come to that. Bouveret syndrome. We'll come to that in a second. So can I just ask you, I wish you guys had the pointer. So which is the stone in this?
In the third picture.
In that third picture of the CT scan.
Yes.
No, which is the stone? So you would think that the stone is this much, right? But no, because of the cholesterol content of the stone, you're only seeing the calcific part of the stone. If I look very carefully at the density of this versus this is denser. So this whole thing is the stone. And this is a common surgical or radiological pitfall. This is actually an emerging cholecystoduodenal fistula in a patient with a large gallstone and will cause gallstone obturation. So this is yours truly. So it's my paper really of subtle but important CT findings of Bouveret syndrome. And this is another example of that. See, what you can see. So I'll tell you, Makonda, how it came by, right? The first case, so I discovered this sign. First case, surgeon like you, gallstone obturation, small bowel obstruction. So the surgeon comes and says that, how is this obstructing? Because the stone is only this small, right? How is it causing obstruction if the stone is that small? So then we realized actually the stone is a lot larger than what is seen on CT. See,
Yeah.
the stone is actually this big. It looks like the bowel, but it is not the bowel. It is actually the cholesterol content of the stone. So we wrote this up actually, and the 4 or 5 cases we wrote up. So I am sorry, these videos are not working. That is a tragedy. Bile duct stone, we have talked about that. So you talked about anatomy. So I just wanted to quickly show you the anatomy. So once again, this is
Bile duct.
the bile duct is the one that is filled with stones along the arrow. This is the portal vein.
Oh,
This is the portal vein. Let me just make this picture bigger, boss. 1 second. Okay. Just very quickly, again, bile duct filled with stones. This is the 3D BIP. So this was
now with the
also
bile duct, it showed up the image of the artery on the right side, on the left of bile duct.
the artery can be seen on the FISP images. It is not going to be seen on the haste images. So this is a haste image. This is a haste image. In a haste image, it is difficult to see the artery. The FISP, which is the anatomical set of imaging, you can see the bile duct very well. So CT cholangiography, we will not talk about that. Okay. So here is a typical MRCP. You can see the bile duct, you can see the pancreatic duct. This is what I was talking to you about, poor ampullary visualization. See the. So what is the etiology of this, do you think? This sort of picture on MRCP.
This will appear like a periampular lesion, which is not seen clearly on MR.
Sorry?
If you have bone bags being dilated.
Yes, but that is true. That is what I was saying, that in this case, this is a double duct dilatation. So therefore, we need to look very carefully for a ampullary lesion or even a sphincter body dysfunction will look like
Yes.
this. But what I'm trying to tell you is that sometimes you will have poor ampullary visualization because of the duodenal movement. And that is a normal variant. You need to, of course, not in the setting of a dilated duct, but in the setting of a relatively non-dilated duct. So this appearance is typically dilated bile duct, but a smooth narrowing across the pancreatic head. This is the classic appearance in pancreatitis, acute or chronic pancreatitis, where the pancreatic head is edematous. And you see this sort of a smooth, non-shouldered, a benign looking stricture. Okay. We have talked about these things. I'm not going to. So endoscopic ultrasound of magnetic cholangiography systematic review. So if you look at this, look at each of these. Presence of obstruction, level of obstruction, stone detection, malignancy detection, and overall. If you compare, which one is which?
No, it's not clear.
So the first row is MRCP, the second row is the US, I think. So as you can see that both are very good. US is better in detecting, is it? 1 second, sensitivity, specificity. Okay, this is just MRI sensitivity and specificity. So you can see the ROC curve, and the ROC curve is actually quite high for MRCP to do each of these, right? Presence of obstruction, level of obstruction, stone detection, malignancy detection. So this is what you were talking about. So intraductal imaging. So I think we have covered all of this. So I'm
Yes,
not.
yes.
Yeah. So here is a typical movie. This is what I wanted to show you. So this is the source image from which I would like to read the actually what is going on rather than the MIPT image, dilated bile duct, borderline pancreatic duct, tiny little, almost like a diverticulum coming from the end of the bile duct. So see that tiny little diverticulum coming. Yeah, normal looking pancreatic duct. So here, the reason I wanted to show you was this. So this is the lower end of the bile duct, right? And okay, I can window it differently, but I was not able to pick up a tiny stone. Here is a cystic duct insertion. Can you see that? This is the MIPT image. You can argue that there is something here, but there was a tiny little stone in this patient, which is not seen on that MR. So this is to give you an example that very tiny calculi are better picked up at US. Cholangitic abscess. Dr. Lushka, we have talked about these things.
Yeah.
Okay, we've talked about.
Yes.
So the last thing is about the bismuth level of strictures. So, type 1, type 2, type 3, type 4, and type 5. And they often have an acute presentation. I think the question that you were asking, this is a pelvic collection. Typically, we know that there is a stricture. And like you say, we first put a drain. This is a subphrenic drain. We first put a drain in the upper quadrant before doing the complete imaging because it can otherwise be obscured. I think you just talked about that question. So মুভিগুলো কাজ করছে না গো, সো এটা দেখিয়ে লাভ নেই।
আচ্ছা, ঠিক আছে।
Just one last thing, Mahanda, is that unfortunately it is still not, for some reason, not available in our country. It is perfectly a routine thing now in the entire Western world, including Singapore. If we have to do this MRI, we have to get this agent from Singapore. It's called Primovist or gadobentate sodium. So this is like CT cholangiography because 20% of this contrast is excreted in the bile duct. So it is actually used to definitively diagnose a metastasis within the liver because it is a hepatocyte specific contrast agent, but it is also excreted within the bile duct. So you can see some very nice acute excretory pictures of the bile duct with MRI. So I think that is, we've talked about hepatico-jejunostomy strictures. Sclerosing cholangitis, I didn't talk about. Choledochal cyst, we've talked about this. And in our country, oriental cholangiohepatitis is not uncommon, RPC. So that more or less covers MRI of the benign biliary tree.
Yes. At least they could write a short note on MRCP.
They can. Good.
Yes.
Thank you.
Thank you very much.
Thank you very much. Thank you.
Shamalda.